Hello, humans! Welcome to the Humanist Society of Greater Phoenix Digital Sunday Speaker event. I'm Ron Russell. I'm the program director here at HSGP. If you like our content, please smash the subscribe button. No, really, smash the subscribe button. Press it. Please do. If you want to contribute in a more material way, please become a member. Donate to our Patreon account and volunteer. Today we have Will Humble, a social contract, public health and public health policy, and why we as humanists see this of value and how it aligns with our 10 commitments. In the manner of critical thinking, right? Sorting out facts from conspiracy theories. No, it's not a human engineered virus or from 5G signals, but what is a good perspective to hold? From the responsibility perspective, how we pay attention to our actions to protect not only ourselves, but others within our orbit. And then empathy. We are all enduring hardships for the well-being of those we love and those we don't know, and how we are caring for the lives of those people. Those are all in alignment with our values. So I'd like to introduce Will Humble. Will is the Executive Director for the Arizona Public Health Association. He is 30 years in public health, includes more than 2 decades at the Arizona Department of Health Services, where he served in various capacities, including the agency director from 2009 to 2015. Most recently, he served as a health policy director at the University of Arizona from 2015 to 2017. He continues to be involved in health policy in his role with AZPHA and as adjunct faculty with the University of Arizona's Mel and Enid Zuckerman College of Public Health. He received a Bachelor of Science in Marketing from Northern Arizona University, a Bachelor of Science in Microbiology from Arizona State University, and a Master's in Public Health from the University of California, Berkeley. He was awarded an honorary doctorate from the University of Arizona in 2015 for his career commitment to engaging partnerships between academic and executive public health. Mr. Humble strongly believes in the use of evidence-based health policy as a means to improving health outcomes. He strives to lead and manage with emotional intelligence. Please give a big HSGP welcome to Will Humble. Hey, Will.
Thank you, and I'm pleased to be a brand new member of HSGP. So thank you for that. Thanks for the introduction, Ron. Before I get started, I want to give a shout out to Roxanne. She's on here, but she didn't activate her camera. I worked with Roxanne for many years at the Department of Health Services, and she came up with the idea of doing this kind of presentation. So. Thanks, Roxanne. And Ron, what's the time frame? I have a bunch of bullets to cover, and I want to pace myself, right? So
you have until about 11:15 for any presentations, and we usually like to leave 15 minutes for questions and answers. So you have roughly an hour and 15 minutes for Q&A.
Okay, that's great. That gives me a lot of time. So I'll introduce the bullets that I want to talk about, sort of the categories, and I'll give you from what I know of where we are with the response and the virus, et cetera. It's moving pretty quickly in terms of new information and so forth. So I think I have some new things that you may not have heard about in public media, et cetera. These are the categories I want to talk about. The surveillance summary, so where are we with the virus, how it's spreading, including, and I want to talk about the predictive models that are out there. Testing, the diagnostic and the serology testing, those are 2 really important components as we move forward in terms of opening the economy, et cetera. Hospital capacity, so there's good news on that regard. I want to cover that. Personal protective equipment, gowns, masks, that kind of stuff. So I'll touch on what's new there. Pharmaceutical interventions. Those are the drug options that are under trial right now for treatment for COVID-19 illnesses. I'll touch on vaccines. Obviously, I'll cover social distancing, the stay home order, and the public policy decisions that surround that and the criteria for that, including also the guidelines that came out from the federal government last week. We could talk about what those guidelines are, what they say. And then I'd like to really touch also on the broader public health implications, because one of the messages that I've continued to try to drive home to our elected officials and others and representatives of the media and members of my organization is that there's a lot more to public health than COVID-19. These public health interventions that are in place right now have profound public health consequences, most especially, well, with the society as a whole, but in particular, people in the service sector, low-income working families, et cetera. And one of the things that I continue to reinforce is that it's important that we look at the totality of the public health consequences of this epidemic and keep one of our eyes on the social determinants of health, because these interventions that we're implementing have really important consequences. And as we think through how to move through this epidemic with respect to public policy interventions, it's important that we consider the totality of those of the response. So let me start with the surveillance summary where we are. So it looks to me, well, I'll speak most specifically about Arizona, since where I have limited time, and that's what I know the most about. So here's what's going on right now is obviously the surveillance, meaning the number of cases and the distribution of cases, et cetera, is dependent on the ability for testing. And testing is, I mean by that, diagnostic testing. And as of about a month ago, we were very, very limited in terms of the resources we had for diagnostic testing. It was nearly impossible to get a test, even for people that were symptomatic a month ago. And so our early surveillance, in terms of the number of cases, the distribution of cases, who's at risk, et cetera, in terms of confirmed cases, has been really limited. That has been getting much better over the last, I would say, 2 weeks. You'll remember about 3 weeks ago, Sonora, Quest, and LabCorp came forward with a diagnostic test and a laboratory. LabCorp, I think, moved their laboratory actually to Tempe, so they're able to do things locally now. So testing capacity became more available about 3 weeks ago, but then there was a shortage of it's really basically a really long Q-tip. So when you go in to get tested for active COVID-19 infection, you get a nasal swab that gets put into a transport media, and the goal is to capture some of the RNA virus on that Q-tip, which goes to the laboratory, and they use what's called polymerase chain reaction, PCR technology, to amplify the RNA on the virus, but converts it to DNA first. But so that's a diagnostic test. But the testing, the specimen collection kit was in short supply. And that has been getting better. But the bottleneck in terms of diagnostic testing has really been because in the last 2 weeks hasn't been the laboratory capacity. It's been the collection kits and the transport media. So the two big manufacturers for the transport media and the Q-tips, the collection swabs, were in Connecticut, which has been hard hit by the virus, obviously, and also, ironically, in northern Italy. So those created some supply chain issues, combined with the fact that there's global demand for these kits. Having said that, I talked to Bob England yesterday, who's the head of Pima County Public Health, and he told me that they have been ordering, they've been on back order for these collection kits, but it's getting much, much better. Supplies are getting better, and you can see that reflected in the number of tests that have been conducted for diagnostic purposes in Arizona over the last 2 or 3 weeks. So it's getting better. Doesn't mean that it is where we need to be, and we could talk about that in a little bit, because testing capacity is a key component to helping us helping elected officials make responsible decisions about how and when to open up the economy. So that's where we are in terms of testing capacity. The surveillance shows that the social distancing interventions are definitely working. One of the things that we saw in northern Italy, in Spain, in New York City, and in the hardest hit areas of the world, that the number of cases had been doubling about every 2 to 3 days. Essentially, that's exponential growth. And that's what I think was the wake-up call for me, is when we saw that trend in Western Europe, with those economies not, with the doubling of every 2.5 to 3 days. Arizona was fortunate in that we didn't get a large bolus or large influx of cases early on, like New York did. And so we had the luxury of being able to implement social distancing interventions and eventually the stay-home order before we had widespread community transmission of the virus. And I think that for that reason, we escaped and will continue to escape the worst of COVID-19. We just were lucky enough not to be a Seattle, Washington, or a New York City, where they got a large influx of cases that ended up with community spread quickly. And so, where are we? So we are doubling our cases about every 8 to 9 days, which is really, really good. It shows that the social distancing is working, that we are not seeing exponential growth in the number of cases. And so that's a really encouraging piece of news. Likewise, on the hospitalization surveillance data, we are also seeing a flattening out of the curve there, with both on ICU bed demand and regular hospital demand. I'm talking about statewide in general. We could talk about the Navajo Nation in a bit, but statewide in general, hospitalizations have been leveling off. Importantly, hospitalization data is really important to look at because it's not testing dependent by and large. So when we look at the total number of cases, et cetera, the total number of cases is influenced by the availability of diagnostic testing. And so when you look at total cases in Arizona, you have to look at that with a little bit through that lens, that the lack of testing capacity over the last month is artificially reducing the actual surveillance data for our state. But that's not the case with hospitalization data, because once you're hospitalized, either in a bed or as in an ICU unit, you are tested. And so so we know who is positive in that regard. And one of the things that we are seeing is that the surveillance data with respect to hospitalization has been really quite stable. Again, encouraging that we're not seeing an exponential growth, because, and again, I have to credit the people of Arizona for taking the social distancing recommendations seriously. This is hard work. Staying home, becoming socially isolated. It's challenging for many people, especially, for example, my parents. They're 85. They're used to being active in lots of things in the community, and this is a challenging time because it's unable to see their grandparents. I go over there from time to time. We sit in the backyard instead of going into the house. That's just one of the stories that are out there. And there are lots of real challenging stories. And so, but the main story here is that the interventions are working. The surveillance data looks encouraging. I'll point you to a resource if you're interested in diving a little bit deeper into where we are, both with respect to number of cases and especially hospital capacity and hospitalizations. There's a model from the University of Washington. It's called the IHME model. And it has, I think, the best reputation within the academic community, those people that are familiar with predictive modeling. They update their model twice a week, using data from across the country to refine their predictive models. And one of the main goals, I would say the main goal for the IHME model is to help states understand where they are in the epidemic curve with respect to their hospital capacity, both beds and ICU. Because remember, at the very beginning of this, the justification for these interventions had to do with protecting our hospital capacity. The original intent wasn't just to slow the number of cases down. It was to depress the cases so that we don't exceed our hospital capacity, and so that we don't end up in a situation like was the case in Madrid, in northern Italy, and in New York City, where there were more patients than there were hospital beds or staff to take care of them. When you look at the IHME models, they update them twice a week. It was updated again yesterday. And I have a link to that on my blog at Arizona Public Health Association. It's called Public Health Today blog. So I've got a link to the IHME model, but it is super encouraging. We are in a position right now where the model forecasts all point to essentially no risk in the next month of us exceeding our hospital capacity or ICU bed capacity or ventilators or all of those things. Those are all scary things as of 3 weeks ago. Nobody really knew if we were going to exceed our hospital capacity. And as a result of the interventions that have been in place and folks' compliance with those interventions, we are in no danger of exceeding our hospital capacity. And you can look at the IHME model, which gives that predictive forecast. And so while we're not out of the woods with respect to this virus, for the meantime, we are in good shape with hospital capacity, which is great. What else could I say about the IHME model? There are some other, if you do some Googling, you'll see some other models, but the IHME has the best reputation. It's through the University of Washington, as I mentioned. It's funded by the Gates Foundation, so they're well-resourced, and they really are doing a responsible job to be objective. There are other models out there. One of them is called Know.COVID-19. I have a little bit, I think in the community, there's less confidence that that is an objective model, but the IHME has a great reputation. And so if you're interested, I would encourage you to go to the IHME model and follow it. You can look at, by the way, the IHME model is, there are tabs for virtually every country. And also within the US, there's a tab for just about every state. So if you have family members or people that you care about in Iowa or Idaho or Louisiana or Florida or whatever, you can go to the IHME model and look at where they are in terms of their surveillance data and their hospital capacity relative in their jurisdiction. And just so you know, the model works not just on the surveillance data, but it also has input parameters so that they update what interventions are in place in the various states. So in Arizona, they account for the fact that we have social distancing, we have a stay-at-home order, but they also are clear to research the nature of our stay-at-home order, because if you followed that, the governor issued an executive order with that stay-at-home order and had a very large number of what he considered essential activities and essential functions, which essentially exempted far more facilities than is the case in other states. And so the IHME model, when they run it, they don't just look at the fact that you've got a stay-at-home order that's an executive order. They also look at the compliance and enforcement provisions, and they look at the scope of the stay-at-home order. So they're not over. They don't give you more credit than you deserve within the model, is what I'm trying to say. So that's kind of where we are on the surveillance. It's super encouraging. let's move to I'll talk a little bit more now about hospital capacity. So some of the advocacy that I've been doing recently in the last few days has been, in my role through the Public Health Association, has been to try to get some of these executive orders scaled back, especially those executive orders that had to do with hospitals. So there's two things that are happening in hospitals right now that I would like to see changed in the coming week. And I'm not optimistic, but I'm hopeful, I guess you'd say, that the governor's going to see that these two things that I'm going to mention make a lot of sense. The first I'll mention is elective procedures. And so Executive Order 2020-10 was an executive order established by the governor about almost a month ago now. That executive order limits, and I'm not sure he has actually the statutory authority for this because they tied it to administrative code and rule. No one's challenged it yet, but the governor has limited elective procedures in Arizona hospitals. And I think there's some misconception in some quarters about what elective procedures are. I talked to some people, and when you say elective procedure, they think you're talking about like cosmetic surgery and stuff like that. And yes, those are elective procedures, but the vast majority of elective procedures are things like hip replacements, knee replacements, gallbladder surgery that's not life-threatening. If you have prostate cancer that's growing slowly but needs to have a surgical removal as part of your treatment plan, those are all things that are considered elective surgeries. And right now, people can't get those surgeries. Now, back a month ago, I was supportive of that executive order because it made sense. Because remember, at the time a month ago, we thought it was quite possible that we were going to grossly exceed our hospital capacity. When you looked at that IHME model, it really looked like we were going to blow through our ICU bed capacity as well as our hospital capacity. That is no longer the case. And so right now, the public policy is based on a model a month ago before the effective interventions, and that stops elective procedures for people who need these procedures that really are profoundly affecting their quality of life. And so to me, it makes zero sense that we still have that executive order in place because of the impact that it's having among Arizonans and people who really need to have procedures. So that's my main public health focus on changing that public policy. The other piece to that, though, is actually financial. So hospitals have a complex blend of revenue sources. And one of the primary profit centers, or the way hospitals keep black ink instead of red ink on the books, is being able to provide general surgery. And a big component of that is elective procedures. And so hospitals, especially rural hospitals, I'm not talking about Banner, they've got plenty of cash reserves. I'm talking about rural hospitals are in a world of hurt right now because their revenue has been tanking because of the elective procedure ban, which, by the way, as I mentioned, there's no reason for that ban anymore because of where we are with respect to hospital capacity because of the social distancing effectiveness. And so, so that's hurting their bottom line in a big way. And there's layoffs that are happening within the hospital systems in rural parts of the state. Some are voluntary nursing layoffs, some is furlough, some people are just taking time off. But it all ties back to the executive order that prohibits these, not all of it. I'll talk about the other part of the equation, but a big chunk of it is this EO 2020-10 that the governor signed a month ago. Another component of what's stressing hospitals' bottom line right now is Executive Order 2020-16. That was an executive order by the governor. I would say that was about 3 weeks ago. And that ordered hospitals across the state to increase their capacity by 50% by April 26th. So what is today, the 19th? So about a week from now, they will have had to increase their capacity by 50%. That's an expensive proposition. What that means is that hospitals are having to sign contracts with locum tenens nursing organizations and nursing contracts that they owe money for to increase their capacity. And again, this was an executive order that made sense a month ago because people were freaking out that we were going to exceed capacity. So the executive order made sense at the time, but now with a comfortable safety margin, it makes no sense to require hospitals to continue to make those investments when there's no indication at all that we're going to be exceeding our capacity. And so those two factors are putting a big stress on the healthcare system, especially in the rural parts of the state. And so those are the two areas where I've been trying to influence public policy. I'm no longer obviously in a decision-making capacity. I don't work at the state health department. I have essentially no relationship with the governor that we have. And just so I'm trying to use whatever influence I can by, communicating sort of back channel with my former staff, and also using my relationships in the media to send the message out there that while those two executive orders and interventions made sense at the time, they no longer make sense, and that they are doing far more harm than good right now. And it has a real life impact on real people who can't get procedures that they need. And by the way, creating a big backlog of procedures. And so if you think about people that have these elective procedures that they need, we've had a month now where they can't get those procedures. And so they are all getting delayed, and it's going to create a big backlog later on this fall. And to me, it just makes no sense to continue those executive orders. So that's where we are on sort of the public policy side of things in that regard. Let me touch now on personal protective equipment. So PPE is, everyone knows what that is, I'm sure by, it's, the masks, surgical masks, N95 masks. N95, by the way, stands for the size of the particles that it filters out. Those are the masks that you see that are white and have like a little square filter on the front of them. So those are used in hospital settings to protect both the patient and the healthcare worker. Gowns, masks, etc. I would say up until about 2 weeks ago, there was a critical shortage of PPE in the healthcare system, but it wasn't widespread. It was spotty. And what the things that I have heard from the field are that the big systems, let's say Banner, Dignity, the larger hospital systems who have relationships with wholesalers for PPE at scale tend to be able to get the attention of PPE wholesalers easier than, say, small critical access hospitals in the rural parts of the state. And so the really acute shortage of PPE has been both in the acute care setting at the rural hospitals, but also at places like community health centers who serve rural and underserved areas, et cetera. And so, and I think part of this is just editorializing, but I think part of that has to do with the fact that, a small hospital is not a huge customer for a PPE wholesaler. And so they know that the COVID-19 epidemic isn't going to go on forever. And, one of the things that happens in business is that you protect your larger customers before your smaller customers. And I think that has led to some of the acute shortages in the rural parts of the state. Having said that, the supply chain for PPE is getting better. The vast majority of PPE is manufactured in China. And so when you think about this epidemic globally, the pandemic, you realize that the initial really big reduction in industrial capacity that happened in China in January and February led to much lower capacity for producing PPE. And so then you had Western Europe really clamoring for PPE back in February and into the early part of March. And then you get the big epidemic that's happening in the US. And so there's this, and by the way, there's demand in South America and in Africa and in Asia, everywhere. So there's all this global demand for PPE and only so much industrial capacity. And so what has been happening in the hospital and acute care settings and the primary care settings in Arizona and across the country is our healthcare providers are being very cautious about how they use PPE, and they're trying to conserve it whenever possible. They don't use a mask when they don't need it. If they can avoid using a gown, they avoid using a gown. And one of the reasons why, if you've got somebody who's in a hospital, and maybe some of you do, that's hospitalized, whether it's from COVID-19 or whatever it is, hospitals are no longer allowing visitors for the most part. And the reason for that is part of that's infection control prevention, but part of that is to conserve PPE, because if you're going to be in the room with somebody who's, for example, got COVID-19, or if there's COVID-19 on the floor, then if you're a visitor, the hospital has an obligation out of the interest of infection control to also protect you as the visitor. And so one of the ways to conserve PPE is to limit visitation, which is also, if you think about it, a huge challenge. These are people who are people need family members around when they're hospitalized. It's a scary time for the patient and for the family. And to not be able to visit your loved one, just think about that. And that policy decision is rolling not out of just infection control, but also out of the fact that the PPE is in short supply. Now, having said that, it's getting better. The supply chain's improving because industrial capacity in China is ramping up, but there continues to be far more global demand for PPE than there is supply. The federal government has what's called a strategic national stockpile. You might hear it referred to as SNS. That was a stockpile of gowns, gloves, N95 masks, surgical masks, et cetera, that the federal government had bought. And that stockpile has been in place really for the last 15 years. When I was at my old job at the health department during the H1N1 pandemic, we ordered the strategic stockpile and received that material. That PPE has already arrived in Arizona. So Arizona's allocation of PPE is already in place and it has already been distributed. And so people can't look to the SNS as, this is what's going to save us, because that's already been distributed. And so, this is just a real challenge out there in the healthcare world. Healthcare workers are making decisions about how to use PPE that they've never had to make throughout their whole careers. They are making decisions that put both themselves at risk and patients at risk. And it's not that they're doing it on purpose or that they want to do it. It's just the fact that, they have to make these decisions because there's enough to go around. So that's PPE. So I'm about 2/3 of the way through my bullet list, and then we could open it up for Q&A. I want to touch on pharmaceutical interventions. This is an area where I think if we could find a medication that's already FDA approved, that's out there, that we can show is effective at helping people who have been infected with COVID-19, who have comorbid conditions like diabetes or obesity or COPD or something like that, to improve more rapidly, it would really help, I think, both psychologically and from a clinical standpoint and from a public health perspective. And so there are a number of clinical trials that are out there happening right now. There was early promise from a medication you probably have heard about called hydroxychloroquine. I wouldn't call it a clinical trial, but an early study that was not peer reviewed from China with 100 patients showed early promise for hydroxychloroquine. Another follow-up case series, again, not peer reviewed, showed that in combination with azithromycin, that combination of drugs is effective. Since then, the trials that have been conducted in New York and other parts of the US have been very disappointing. In fact, I just put up in my policy update that went out today, have a link to a follow-up study on hydroxychloroquine that showed no effect. In fact, it posed obviously more risk than it did benefit for patients, because it showed that there was no clinical improvement in the cases that got hydroxychloroquine in combination with Zithromax, and had some side effects that were bad. So looks to me like hydroxychloroquine is one of the ones that we can say is unlikely to be of therapeutic value. However, there is some good news. There's and I'm not going to say this right, but resmanavir, or that's not the exact name of the drug. There are some clinical trials happening with resmanavir. It's from a company called Gilead Sciences, I think is the name of the corporation. That's in clinical trial, and that has shown, again, not a peer-reviewed study. There's not enough time. You know, peer review takes a while, and we're in an environment that's moving very quickly. So, but there is some early evidence that the resmanavir is helpful in not for prophylactic. It doesn't prevent infection, but once you are infected, it does appear that it may be helping people recover much more quickly than they would have without that medication. And so, if it turns out that that medication is helpful, it can really, really help throughout the rest of this. You know, before we get the vaccine, there's still going to be, even if the social distancing, you know, stops the community spread or slows it down this summer, there's still going to be sporadic cases that continue to happen. And if we can identify a pharmaceutical intervention or a drug that's already FDA approved that can be repurposed, it could really have a profound effect, not just on treatment, but on people's psychology. People can become less fearful of this virus if they know that there's a treatment that can be effective, if they have some of the more complicated consequences from infection. There are a number of other drugs that are under review. To me, it looks like this resmanavir from Gilead Sciences. It looks the most promising right now, but there are other medications being tried as well. Again, if you think about what the goal for these drugs are, it's you know, 80% of the people that are infected with this virus, at least, probably more than 80%, are asymptomatic. And for those people that are symptomatic and hospitalized, these are medications that you would get on board early in hospitalization, and it's not going to cure you immediately, but it may prevent a person who's hospitalized from progressing to needing an ICU bed, for example. So you could keep them on supplemental oxygen and stop them from needing to be intubated and get onto a artificial ventilator, et cetera. So, so that's where we are on pharmaceutical interventions. Going back to, I want to go back to surveillance for just a second, because there's something that I left out that's really important. I talked a lot about the diagnostic testing, and that's, you know, the testing to see if you are infected with the virus actively. That's the nasal swab that gets into the transport media, where you get a diagnostic test. Another important part of surveillance is looking at the serology, and that is where it's not a diagnostic test, but rather if, and I'll use my daughter as an example. She lives in Brooklyn. She's home now. She went into 2 weeks of quarantine when she got here up in Prescott. But so there's a decent chance she lost her sense of smell for 2 weeks, she says, and taste, which is anecdotally a symptom, especially among young people, of COVID-19 infection. And the question is, and this will be important for her and many, many people like her, really all of us, is to figure out who's been infected and recovered and didn't know that they were infected with the virus. And the way you answer that question is with serological testing. So it's essentially a small amount of blood that you would get from the patient or from the person, and you look for the presence of antibodies. There's two kinds of antibodies you look for: IgG and IgM. IgM is the antibody response that your body produces first, right off the bat. And it's like the emergency response antibody, I guess you'd say. And then after a few days, the IgM transfers dominance, the immunoglobulin transfers dominance to IgG. And so the serological tests essentially can look at a population of people and say, have you been exposed to the virus and recovered? And if you show the presence of IgG antibodies, that's super important because it tells you that you were infected with the virus and recovered, but were asymptomatic. It also tells you that you can safely do things that you didn't know you could do because you've been infected with the virus and are very likely not going to be spreading the virus to other people, nor will you get it again. And so one of the efforts that's underway across the country and about to happen in Arizona is wide-scale antibody testing. And the reason I wanted to mention this, there's a new study, which is peer-reviewed, that came out a couple of days ago from Santa Clara County. So that's in California. And they did community sampling and looked for antibodies out there in the community. And what they discovered was that the conclusion of this paper was that for every known case, confirmed case of COVID-19 in Santa Clara County, there were between 50 and 60 cases that we didn't know about. So so think about that for a second. For every known case, there were 50 more people that were infected and recovered. Either they were asymptomatic or had mild symptoms, et cetera. And so if that continues, and if we continue to see results like that, it suggests that we might be a long way towards what's called herd immunity already. And the way you stop these epidemics in the end is with something called herd immunity, where enough people are infected and recover that whatever the agent is, in this case the RNA virus, has a difficult time finding new hosts because so many people have already been infected and recovered. And once you've got the antibodies to it, you don't get symptomatic again and you don't spread it to others. And so the results, at least in Santa Clara County, suggest that far more people have been infected with this virus than we know about, which means that we're much further along with respect to herd immunity than we realized. There's another study last week from New York where they looked at all the pregnant women that were within a trimester of delivering in New York City and did antibody testing of that cohort population. And what they found is very few, I think there were 3% of them that had any symptoms, but 20% of that cohort had antibodies to COVID-19. So think about that. So that's a small n. It was like a 350 person study. But if that's the case in New York City, broadly, New York City is close to herd immunity soon, which means the end of the epidemic in New York City. Again, early data, we don't know if it's going to bear out. There is, in other places, there is an effort underway by the U of A, who got $3 million of general fund money from the state to conduct widespread antibody testing and they're in Arizona. Their goal is to collect samples and analyze them from 250,000 people. And they're focusing on healthcare workers and first responders. And so within the next month, we should begin to see some data from that surveillance study to give us more information about where we are in Arizona with respect to herd immunity. Let me talk about vaccines for a bit. So I have no doubt that we're going to have a vaccine for the coronavirus. It's going to happen. Question is when. The normal process for creating a vaccine takes a long, long time. That you start with trials for safety, and those are usually small scale. First, you develop a vaccine, and there's different ways you can do it, different routes of administration, et cetera. But you start with safety, small-scale safety studies, and then you move to larger scale safety. And once you're convinced that a vaccine that you're testing is safe, then you can move to efficacy or does it work stage. And then you start using much larger cohorts of people that you inject with the vaccine, and then measure their antibody response. There are a number of vaccines underway that are being tested for safety right now. I'm not familiar with any that are in the efficacy or the does it work stage. If everything goes right, there's possible we could have a vaccine that's getting into production by, say, November, December. It may be longer than that, but it does. But one of the things it does do is it poses interesting like social justice questions, because when a vaccine becomes available, it's not like there's going to be 300 million doses available in the U.S. Right away. It's going to come through the production line, and the question becomes, how do you roll out that vaccine, and who gets the vaccines first, et cetera. So interesting social justice questions that come with prioritizing who would get the vaccine. But I do believe that something is on the way, but it will be several months. I want to touch now on sort of the effect of these interventions, and then we could open up for Q&A. From the very beginning of this, I have been really trying to send as many messages to as many decision makers as I can to ensure that they realize that the interventions and the decisions and the public policy decisions that our elected officials make consider more than just COVID-19, that the interventions themselves have profound public health consequences, especially among working families, people in the service sector who are losing their jobs. They're losing their ability to make a living and to pay their bills or to pay their child support or you name it. It's also causing people to live in unnatural environments where they're locked up, well, not locked up, but people are confined to their homes in situations that might not always be healthy. Let's face it, there are situations out there where there's domestic violence or those kinds of situations, both for all family members, but especially kids. Kids have losing their social connections that they have at school. Seniors especially are cut off from the rest of their family. And so all of these interventions have their own public health consequences, from suicidal ideation to completed suicides to substance abuse, alcohol abuse, unhealthy environments, domestic violence, child abuse. So it's really important for folks to think in these decision-making capacities, to think about the interventions themselves as having their own public health consequences. And so for that reason, I think it's important that we begin backing off of these interventions as soon as it's responsible, as soon as we can responsibly do it. Because it's having real life consequences, especially with working families, not just working families, but everybody. So with that, states are now in a position of thinking through how they back off of the stay-at-home orders, the social distancing orders, the closure of bars and restaurants, et cetera. And we see some states starting to back off of some of those things. The federal government put up a document with sort of some guidance for states to consider as they think about what interventions to back off on and at what pace. They have a set of gating criteria, and I won't go into the details of what the gating criteria say, et cetera, but but states are really in the position of starting to think about ways and strategies and the pace at which they're going to start backing off of some of these interventions. But all of it really depends, I think, on a couple of things. Number one, the ability to have quick diagnostic testing so that you can identify cases quickly, and so that you can then do contact tracing. Because what's happening right now is, as I mentioned at the beginning, we're right about at the hospitalization and transmission peak for this virus, and we expect it to go down over the next month. And by early June, we should be in a position where the number of new cases in Arizona is actually quite small, which provides public health with an opportunity to actually do contact tracing. That's not possible right now. There's way too many cases. The workforce just isn't there to do contact tracing and ensure isolation and quarantine among infected persons. But a month from now, we expect the transmission to be so much lower that if you had quick testing and if you had capacity within the county health departments to do the contact tracing, you could essentially go in and identify cases quickly, do interventions, get them into isolation and quarantine, and prevent future spread of the virus. But that depends on having adequate testing capacity and adequate staffing to do that kind of contact tracing. So I think with that, I've covered just about everything. The one area I haven't covered yet is special populations. And so I should touch on that before we open it up to Q&A. It looks to me like like in other states, the biggest risk factors are for complications are being elderly, over 70, being obese at any age, and having type 2 diabetes at any age. So those are the and high blood pressure is another one. Unresolved, like high blood pressure that's not being managed. So those are the biggest risk factors. And where we see that playing out in a dramatic way in Arizona is on the Navajo Nation, especially in the Tuba City area, but really across the whole Navajo Nation, where we see a lot of deaths coming out of that community. And, the Native Americans represent about between 4 and 5% of Arizona's population, but they are north of 15% of the deaths. And I think we can attribute that to a couple of different things. Number one, the prevalence of the comorbid conditions, especially diabetes 2, among that population, but also the treatment conditions up there. And I'm not saying there's anything bad about the Tuba City Hospital. It's just that when you think about the distances and as I mentioned about hospital capacity at the beginning, overall hospital capacity is fine in Arizona. That's not the case on the Navajo Nation. They are really stretched to the limit of their capacity. And many of the patients from the nation are ending up in Flagstaff Regional, which, by the way, isn't the greatest place for them to go because it's at 7,000 feet. And it's the respiratory illness like this. There's a lot less air up there. And so it's not exactly the best place. It's better to be at a lower elevation. Anyway, so with that, I've done a lot of time. I've talked for about an hour now. And so Ron, or I don't know, what do we do from here? Should I look at